Dr. Kamran Afzal is the head of pediatric nephrology in the JLN hospital attached to AMU, and he'll be talking to us about infection-related glomerulonephritis.
Pointer. Good afternoon, everyone. At the outset, let me thank Dr. Pankaj, Dr. Aditi, and the organizers for inviting me to deliver this talk on infection-related glomerulonephritis. This is the outline of my talk. A 7-year-old boy presents with a dark-colored urine. He has history of swelling around his eyes for the past 3 days. He had sore throats about two weeks back that resolved on its own without any treatment. There is no history of fever or rash or joint pain. On examination, he had some periorbital edema, a mild hypertension, and no pallor rash or joint swelling. His urine analysis revealed gross hematuria, proteinuria, 2+, and red blood cell casts. Serum creatinine was 1.2. The C3 level was 45 milligram per deciliter, which was low, and the ASO titer was positive. So the diagnosis is straightforward: acute post-streptococcal glomerulonephritis, which is the prototype of the infection-related glomerulonephritis, which is largely seen in pediatric age group. The child was managed with salt restriction, diuretics, calcium channel blockers were given for hypertension, and a close monitoring of the KFT and blood pressure was done. The gross hematuria and proteinuria resolved in the next few weeks. The renal functions normalized. His complement levels returned to baseline at the end of about 8 weeks, but he continued to have some microscopic hematuria, which also resolved in 4 months. This is the typical course that you see in a patient with post-streptococcal glomerulonephritis. So what is infection-related glomerulonephritis? This is immune-mediated glomerular injury, which is triggered by an extrarenal infection. And this infection could have a latency, that means a latent period before an infection, when we call it as post-infectious glomerulonephritis, of which PSGN is the prototype. Or you could have a glomerulonephritis setting in the presence of an active infection, which is syn-infectious, and staphylococcal-associated glomerulonephritis is the prototype of this. So while PSGN is the most common cause of IRGN in pediatric age group, in adults, the cause is usually non-streptococcal. So the definition of IRGN requires at least 3 of these criteria: presence of clinical or lab evidence of an infection, depressed serum complements, and a biopsy evidence, which is C3 dominant or co-dominant glomerular immunofluorescence findings, endocapillary proliferation and exudative glomerulonephritis, and hump-shaped epithelial deposits. But there are varying definitions that have been used, and this particular definition might be more applicable for adults rather than pediatric, because in PSGN, most of the time you will not be doing a biopsy. So besides streptococcal, there are a lot of other infections, both bacterial, viral, fungal, as well as protozoal, that are responsible for causing glomerulonephritis. But of all these, bacteria are the most common, and among the bacteria, the streptococcus and staphylococcus are the most important cause. So essentially, IRGN is a bacterial infection-associated glomerulonephritis, and it can be classified into post-infectious or post-streptococcal when it has a period of latency with abrupt onset of nephritic symptoms, largely occurring in pediatric age group, but also seen in adults. The staph-associated glomerulonephritis, which is caused by Staph aureus or epidermidis, and the infection usually is active when the glomerulonephritis develops, and since the infection is present, usually immunosuppression is avoided in these patients. The other category is glomerulonephritis with other infections, of which one is infective endocarditis, the other is shunt nephritis, but it could also happen with deep-seated infections and with in patients with having prolonged indwelling central venous catheters. So these are some of the common infectious syndromes that are associated with glomerulonephritis. As I said, skin and throat infections, they are more common with streptococcus infections, but not just pyogenes, but other streptococci as well. Then infective endocarditis, which could be because of viridans, but in recent times because of Staph aureus and epidermidis as well. Pneumonia, central line infections and visceral abscesses, and shunt nephritis. Epidemiologically, post-infectious or post-streptococcal glomerulonephritis is supposed to be a disease of disparities. So it's more commonly seen in underprivileged and low-income countries than in the more developed countries. And one large study showed that the incidence among the pediatric age group in the less developed countries was around 24 persons per 24 cases per lakh person year, while in more developed countries it was around 6 cases. Similarly, in the adults also, while it was the incidence is lower in the adults, but there is also a difference between the developed and the developing world in the adult population as well. So you can see that the incidence in India is much higher than in some of the developed nations. Also, the trend has shown that over since 80s, with improving conditions, the incidence has declined over the time. So what are the pathogenic factors that cause post-streptococcal glomerulonephritis? One, of course, is the presence of a nephrogenic strain of group A beta hemolytic streptococcus, which a number of serotypes, M types, have been defined as causing post-streptococcal glomerulonephritis. But not everybody who develops infection with a nephrogenic strain would develop a infection-related glomerulonephritis, which means that there must be some host susceptibility factors responsible, which include some HLA types as well as some polymorphism, especially in the endothelial nitric oxide synthase gene. So how do the infections really produce glomerulonephritis? There are several ways by which the infections may produce glomerulonephritis. One, of course, is the antigen may produce immune complexes, either in the circulation or they may form complexes in situ. That means the antigen gets deposited into the mesangium or in the glomerulus, and then the antibodies come and bind to these antigens. The other ways that it could happen through is by direct toxicity involving the innate immune system, or by autoimmunity because of molecular mimicry. For example, the streptococcal pyrogenic exotoxin, which is a release, which is a super antigen. It produces mimicry with the endothelial antigens, and therefore antibodies may go and bind to the endothelial antigen because of this molecular mimicry. A number of antigens of PSGN have been implicated in the causation. Earlier, M protein was thought to be one of these, but in recent times, it has been discarded as a putative antigen. Some of the putative antigens now supposedly producing this are nephritis-associated plasmin receptor, which binds to plasmin, degrades the GBM, and causes leukocyte infiltration. The other is SPEB, as I just said, which also is a plasmin receptor and stimulates the leukocyte infiltration and causes glomerular basal membrane damage. The others that could develop is because of streptokinase by converting plasminogen into plasmin, or neuraminidase, which can activate the MBL complement pathway. So how does PSGN actually develop? So while the nephritis-associated plasmin receptor, which is a glyceraldehyde phosphate dehydrogenase and a plasmin receptor, it binds to the mesangium and GBM, or the immune complexes get deposited here. Because it's a plasmin receptor, it entraps plasmin, and the sustained activity of plasmin results in damage to the GBM and recruitment of inflammatory cells, which results in the immune complex mediated glomerulonephritis. So in this figure, you can see that the nephrogenic antigens by themselves, usually they are negatively charged, so they are repelled by the GBM. But by interacting with the plasmin or plasminogen, they tend to activate certain enzymes like collagenase or these MMP, metalloproteinases. These proteinases or enzymes, they then degrade the endothelium, helping it to lose its negative charge. This helps in penetration of the antigen or the antigen-antibody complex, which then gets deposited in the subepithelial spaces. And this is what we generally see on electron microscopy as a subepithelial hump. And these humps also result in effacement of the podocytes, and that's why you see proteinuria. So the clinical features of post-streptococcal glomerulonephritis I have just discussed with the case. Most of the time, these patients fall in the age group of 5 to 15 years. So it's rare to see post-streptococcal glomerulonephritis below 3 years of age. And usually there is a male preponderance, and 5 to 10% of these cases follow pharyngitis, and a larger number of patients generally follow the skin infections. There are seasonal and geographic variations, and epidemics have also been reported, not just in pediatric age group, but also involving the adults. The latent period following an infection is usually 1 to 2 weeks following a sore throat, and around 3 to 6 weeks following skin infections. Large number of patients are asymptomatic, and that is why we are unable to say exactly about the incidence of the disease. The clinical spectrum varies from asymptomatic microscopic hematuria to ranging up to a rapidly progressive or crescentic form of disease. But typically, the patient presents with a nephritic syndrome-like picture in almost 90% of the patient, and nephrotic syndrome or RPGN is a rare presentation. However, some proportion of patients might develop encephalopathy seizures, usually secondary to accelerated hypertension, or even LVF, and PRES could also be seen. Most of these potentially serious life-threatening complications, if managed well, they are easily reversible. So the clinical presentations, largely you see there is more likely a history of pyoderma than a history of pharyngitis. Hematuria is present in almost all patients, although gross hematuria may not be seen in all the patients. Edema and hypertension are also most often seen in most of the patients, although emergencies in hypertensive emergency is seen only in 1/3 of the patients, and encephalopathy is rare. Similarly, oliguria is also, although the urine output may be low, but typical oliguria could be seen in much fewer patients. The typical lab findings are in the form of a urine analysis revealing dysmorphic RBCs and with or without RBC casts. Occasionally, there are WBC casts and presence of WBCs as well. This does not mean that these patients have UTI. The patients may have elevated blood urea nitrogen, but the creatinine levels are not as high. The albumin levels could be low in up to 40 to 46% of the patients. Although proteinuria is seen in 60 to 70% of the patient, a nephrotic range is seen in fewer patients. A low serum C3 is almost universal, so that's a very important diagnostic tool to be used. A combination of low C3 and C4 may be seen in a small proportion of patients. Elevated ASO or elevated DNase B is seen in a large number of patients, variable and reported in different studies. Also, ASO titer is more likely to be higher after a pharyngeal infection, and anti-DNase B is more likely to be high after skin infections. Sore throat as a evidence of preceding infection is seen in much smaller proportion of patients. So biopsy is generally not needed for the diagnosis of PSGN, but there are certain indications for both in the early phase as well as in the recovery phase of the disease. A rapidly progressive course, a persistently low GFR that persists beyond 2 weeks, patients presenting with nephrotic range of proteinuria, those who have a normal complement or those who have extrarenal manifestations, they should be biopsied early. Those in the recovery phase, if they have a persistently low complement beyond 3 months, or if they have a persistence of proteinuria beyond 6 months, are important candidates for subjecting the patients to biopsy. For adult patients, the threshold for biopsy is usually lower. Pathologically, the typical finding is to get an acute exudative proliferative glomerulonephritis. This is a normal glomerulus. In patients with nephritis, you see glomerulomegaly with exudative and endocapillary proliferation with infiltration with neutrophils early on and with lymphocytes and monocytes in the later stages. Occasionally, one might see diffuse endocapillary proliferation with a few crescents. Crescentic form is less often seen. On immunofluorescence, there are deposits, granular and coarse deposits, both in the mesangium and along the capillaries, which gives it a starry sky appearance usually in the earlier stages. Later on, these get confluent and produce a more garland-like pattern. These are deposits generally of C3, more of C3 than of IgG. Earlier on, they may be even IgM deposits. In the resolution phase, usually you see more of a mesangial depositions rather than deposition along the capillaries. On electron microscopy, the characteristic finding of an electron-dense subepithelial hump is seen. A neutrophil is also seen here, which indicates that there is stimulation by this deposit. Also, the timing of the kidney biopsy results in different pathological features that are noted. So while typically the presentation clinically is of an acute nephritic syndrome with a diffuse global exudative proliferation, in the early biopsies, one might see that this proliferation is more focal and segmental rather than diffuse. Also on immunofluorescence, you see more of a starry sky pattern in the early biopsies, while the later biopsies may show both a similar pattern or a garland-like pattern. Also, you could also see not just subepithelial, but also subendothelial deposits in patients with a typical feature. And in late biopsies, which are done generally for persistence of hematuria or proteinuria, you might find more of a mesangial proliferative pattern rather than an endocapillary proliferation. And similarly, the deposits are also lesser and more mesangial in distribution. Also, on electron microscopy, you will find that the humps are more located in the mesangial shoulders or notch rather than in the other parts of the membrane. The management of post-streptococcal or post-infectious glomerulonephritis, since the infection has already passed off, is largely supportive, which involves maintaining fluid and electrolyte balance, avoiding nephrotoxic medications, and monitoring and managing hypertension and AKI. The antihypertensive that is generally preferred is diuretics alone, because usually salt water retention is the reason for this hypertension, or it is combined with calcium channel blockers. We generally avoid ACE inhibitors or ARBs early on because of the decline in GFR in the early stages. Antibiotics are not needed, but may be needed if active infection still is present in some of the cases, or may be preferred during epidemics. Immunosuppression does not have a role except in patients who have a crescentic presentation or who have a diffuse proliferative disease with severe persistent renal dysfunction. And I think this part will be discussed later by Dr. Pankaj Hari. The typical course is that the disease is largely benign, and 95% of the patient would generally resolve. Only 5% are likely to have a more catastrophic course with a rapid progression of renal failure. So as you can see, the C3 levels are low very early in the disease, and they tend to return back to normal just before around the end of 8 to 10 weeks, definitely by 3 months. The longest that has been reported is around 9 months. The microscopic hematuria that you see with this red line, with this green line, you see it could persist on for months, sometimes even for years. The exact significance of that is not really well defined. The other IRGN is a IgA dominant kind of infection related, which is usually because of Staph aureus, and that is why it is called as a Staph aureus associated glomerulonephritis. This is chiefly a disease of adults. The younger populations, chiefly IV drug users, could have an endocarditis of the right heart and have also developed similar disease. Mostly it is because of MRSA or MSSA, but occasionally staph epidermolysis may also be involved. Rarely the gram-negative organ bacteremia could give rise to IRGN. The usual history is that patients have some kind of skin infections like cellulitis or abscess, or they have some deep-seated abscesses or osteomyelitis or arthritis, following which the disease develops. These patients generally have a low C3, only about 30 to 70% of the patients. So you can see it's lower than what you see in patients with PSGN. And the serum C4 is usually normal. Some a small percentage of patients could have ANCA positivity, and these may have systemic symptoms. And systemic symptoms may include leukocytoclastic vasculitis, resulting in a typical purpuric rash akin to what you see in IgA nephropathy. IgA vasculitis. So AKI often is severe, and these patients have microscopic hematuria, and often have a nephrotic range proteinuria. So proteinuria is more severe, and the deposits are often more subepithelial rather than subendothelial in these. And of course, there is an ongoing infection. Sometimes when a biopsy reveals the likelihood of a IRGN or a IgA dominant disease, then one must look closely for deep-seated infections, because treatment of infection is crucial for resolution of the glomerulonephritis. The renal biopsy findings are similar to what you see in PSGN, except that occasionally you could see necrotizing lesions and intracapillary hyaline pseudothrombi. Also, the ATN in this disease is often more severe. There are deposits of IgA which are mild to moderate, around 1 plus to 2 plus staining, but C3 staining is more moderate to strong. That means 2 plus or 3 plus staining of C3 is there. Occasionally, in about 40% of cases, you could have a co-dominant IgA and C3 deposits. Also, the subepithelial humps that you see in PSGN are less often seen in patients with IgA dominant disease. So the criteria for diagnosis of SAGN is that you should have a culture-proven staph infection, either active or in the recent past, and acute proliferative glomerulonephritis with glomerular deposits of IgA and C3 should be seen, and the typical presentation of AKI with a nephrotic range proteinuria and occasionally microscopic hematuria should be seen. The treatment revolves around giving the appropriate antibiotic, and these antibiotics for deep-seated infection should be given for prolonged periods around 4 to 6 weeks. The supportive management revolves around managing the acute nephritis. Corticosteroids are avoided because of fear of flaring up of the infection and may have an adverse effect on the outcome. Also, the outcome of IgA dominant disease is less favorable than what you'd see in PSGN. End-stage renal disease is seen in about 20 to 80% variably in different reports. There is also varying persistence of renal dysfunction in the remainder of the patients. So the poor outcome also is likely because of the underlying pre-existing renal comorbidities that are seen in adult patients who develop this. Usually these are patients in the age group of 50 to 80 years, so they often have diabetes, hypertension, etc. when they develop the disease. So the underlying illness or comorbidity could also affect the outcome of the illness. Endocarditis-associated GN is seen in reports of 2 to 60% of the reports. And Streptococcus viridans previously was the more common organism, but in recent times, Staph aureus and epidermidis have also been seen. Also, infection by Staph aureus or endocarditis by Staph aureus is more likely to produce endocarditis-associated GN than by non-Staph disease. So almost 31% versus 19%. As in IgA dominant disease, you could have purpuric skin rash or ANCA positivity in up to 28% of the patient. These patients have AKI and nephritic urine sediments as in IgA dominant disease, but a nephrotic range proteinuria is less common in patients with endocarditis than what you see in the other forms of the disease. The C3 is low in only about 53% of the patient, and C4 could be low in about 19% of the patient. Treatment again is giving specific antibiotics, and sometimes you might have to replace the valve if the infection persists. Immunosuppression is better avoided in these patients, and in fact is associated with adverse outcomes. The largest retrospective series reports a complete recovery in only about 32% of the patients, with persistent renal dysfunction in 37%, ESRD in 10%, and death being reported in about 21% of these patients. Lastly, the shunt-associated nephritis is seen in 0.7 to 0.2% of patients, and it was seen more previously because ventricular atrial shunts were placed. It is rare in patients who have a ventricular peritoneal shunt. They usually develop months to many years after the insertion of the shunt, and the implicated bacteria are usually Staph epidermidis and aureus, less commonly Pseudomonas. The patient generally appears to be unwell, has recurrent fever, anemia, hepatosplenomegaly, sometimes a skin rash and cerebral symptoms because of the disease. During active infections, ANA could also be positive in these patients. These patients often have nephrotic range proteinuria, hematuria, and hypertension. And like in endocarditis and IgA dominant disease, ANCA may be positive in some portion of the patients. The renal histological findings are similar, and the treatment is actually to give antibiotics and remove the shunt if the infection persists. Again, recovery is slightly better than what you see in endocarditis-associated GN, but recovery is seen only in about 50% of the patient, and mortality is seen in about 10% of the patients. So one must differentiate between PSGN and SAGN. While PSGN is mostly a pediatric disease, SAGN is seen mainly in adults and elderly patients. Young patients with IV drug use could have the disease. Most often, PSGN is because of a group A beta hemolytic streptococcus, while SAGN is because of MRSA. And so you have a history of either skin infection or tonsillitis in patients with PSGN, while SAGN, as we have discussed, could have more deep-seated infections or endocarditis, etc. There is a period of latency with post-infectious glomerulonephritis like PSGN, but in SGN, there is no latent period. Also, you find that more consistently low C3 values in PSGN than you would see in SAGN. The outcome is much better in APSGN or other forms of post-infectious glomerulonephritis than in SAGN, where you could have an unpredictable course, and often there are risk factors that decide the outcome of the disease. So the key message is that PIGN is the commonest in children. Of this, post-streptococcal is the commonest. It's usually a self-limiting disease with excellent prognosis. Kidney biopsies has only a few indications in such children, and treatment is largely supportive. The role of immunosuppression is controversial in these with limited evidence, and only for possibly for crescentic glomerulonephritis, immunosuppression is not used in these patients. For IgA dominant disease in adults, usually there is an ongoing infection and the prognosis is poor. And if you have a biopsy finding that suggests the possibility of a IgA dominant disease, and you do not have evidence of an infection, then one must look actively for infection. The treatment of staph-associated glomerulonephritis revolves around managing the infection rather than immunosuppression. Thank you.
Thank you, Dr. Kamran, for a very comprehensive presentation. And if there are any questions to Dr. Kamran, we'll take them. Awesome. So if there are no questions, then we can go to the next talk. The next talk is to be taken by Dr. Pankaj Hari. He's the head of pediatrics at AIMS, and he's also the head of the division of pediatric nephrology here. And he'll be talking to us about crescentic glomerulonephritis, evidence-based update. Sir, over to you.
Okay. Thank you, Mukta. So I'll be talking about briefly about the pathogenesis of crescentic glomerulonephritis, and I will largely cover the ANCA vasculitis because it's the key condition that results in crescentic GN. Although in children you still have immune complex mediated RPGN. I will talk about the classification of ANCA vasculitis and the key trials that have been done in last 5 years, and about the treatment guidelines for ANCA vasculitis. Now, most of the therapy guidelines have come from the ANCA vasculitis, and because that's the one which is more common in adults, and they have studied it more with randomized controlled trials. So a crescent is described as more than 2 layers of proliferating parietal epithelial cells that should be affecting at least more than 10% of the glomerular circumference. And the clinical presentation is with hematuria, proteinuria, hypertension, and a rapid decline in renal function. You could see that the 3 most common diseases that would result in crescentic GN, these include anti-GVM disease, ANCA vasculitis, and immune complex RPGN. And these are the common factor there in all these 3 conditions is the presence of endothelial injury. And so you'll find that the endothelial proliferation is seen in almost all of them. And most of these conditions would be associated with major proportion of patients will have crescents. And the clinical course is very acute with the CKD occurring very rapidly over a period of months in a significant proportion of patients. On the other hand, you could also have crescentic GN in other conditions like C3 glomerulopathy as well as IC-MPGN. And these you could see that the endothelial proliferation is much lower as compared to the ANCA vasculitis. And they usually have a chronic course with CKD occurring over a period of, in 1/4 of patients over a period of 5 years. So if you look at the etiology of crescentic glomerulonephritis in children, this is a systematic review and meta-analysis, systematic review which is done by Dr. Jitendra from our unit, and where he took all these studies, which were more like a cohort studies of prospective as well as retrospective, and this included about 1,500 odd patients. So immune complex RPGN was the most common, it's at 76% as opposed to post-immune, which is synonymous with ANCA vasculitis. And the anti-GBM disease was seen in just 5%. And when we looked at in a very small study about 15 years back into the clinical presentation of crescentic of the immune complex crescentic GN and post-immune GN or the ANCA vasculitis, we could not find much difference in the clinical presentation. Well, we do know that ANCA vasculitis may be associated with the extrarenal manifestation, particularly if it's a granulomatosis with polyangiitis. So we could see that ANCA vasculitis, immune complex GN, and anti-GBM disease, and even C3 glomerulopathy all can result in injury to the GBM or the subendothelium, either through immune complex deposition or complement activation. This vascular injury would result in rents in the GBM, which will lead to leakage of plasmatic procoagulants within the Bowman space. Also, there are rents which are formed in the Bowman's capsule, which will result in influx of various inflammatory cells into the Bowman space. And this would instigate proliferation of parietal cells, which finally will result in tuft collapse and a decline in the single nephron GFR. So if we see ANCA vasculitis, it is chiefly consists of GPA, microscopic polyangiitis, and the EGPA, which is much less common. There are EULAR criteria for classification criteria for classifying patients into granulomatosis with polyangiitis, and these include at least 3 of these 6, either in the form of renal involvement, histopathology of granulomatous inflammation, upper airway involvement, laryngotracheobronchial involvement, or a pulmonary involvement on X-ray or CT chest, and ANCA positivity either for the C ANCA or the P ANCA. Pediatric criteria for classifying macroscopic polyangiitis are not available, but chiefly they would consist of either a necrotizing vasculitis, evidence of pulmonary capillaritis, or a rapidly progressive glomerulonephritis. On the other hand, EGPA will have either manifestations in the form of asthma or eosinophilia with necrotizing vasculitis and the presence of eosinophil-rich granulomatosis. So the key underlying pathogenic factor in ANCA vasculitis is the ANCA antibodies, and it generally is a very good biomarker of picking up this disease. And we see that in both GPA and MPA, you will have ANCA antibodies positive. And it's mostly the C ANCA which is present in granulomatosis with polyangiitis. On the other hand, in the macroscopic polyangiitis, it is the P ANCA or the MPO ANCA. Previously, there was a recommendation in 90s that if you have to screen for ANCA, you should be first doing the immunofluorescence and then also the ELISA, because combined would result in better sensitivity and specificity. But more recently, now it's been understood that with the availability of the new solid phase assays, particularly the immunoassays like direct FEIA or the fluorescent enzyme immunoassays, you may just use ELISA, and immunofluorescence doesn't really add much to your diagnosis. So if you have an ELISA positive, negative, and you still have a very high index of suspicion for ANCA vasculitis, you may still do immunofluorescence, but by and large, you can just do ELISA if your lab is testing with the new generation ELISAs. So what about the other diagnostic evaluation? One would look at the renal function, chest X-ray, CT chest or sinuses if depending on the clinical symptom, urine examination, protein creatinine ratio, and majority of these patients you will also like to exclude the lupus, ANCA, as well as relevant biopsy, and particularly renal biopsy is most important in these patients. So what KDIGO suggests that if your patient presents in with clinical features very compatible with ANCA vasculitis, and you have the ANCA antibodies positive, you may begin the treatment, commence the treatment without even waiting for the kidney biopsy, and whenever feasible, you could do a kidney biopsy. On the other hand, if the ANCA antibodies are negative, then you should really do a biopsy first and see if there's a post-immune kind of a picture in the kidney biopsy. You should consider treating it as ANCA vasculitis. So now coming to therapies of ANCA vasculitis, This is a disease in adults which has been studied a lot, and various interventions over a period of last 30 years have been tried. Initially plasma exchange was studied, then came the methylprednisolone pulses, IV cyclophosphamide, then rituximab, and in the last 5 years it is the avacopan, and the plasma exchange has been again revisited, as well as people have tried to use lower doses of corticosteroid in induction. So I'll be covering the recent trials. And about the maintenance, we have the studies that compared cyclophosphamide with azathioprine for maintenance, the MMF versus azathioprine, and then rituximab versus azathioprine for maintenance. And there were multiple trials of rituximab to be used as maintenance therapy in ANCA vasculitis, because ANCA vasculitis maintenance therapy is very important because it is associated with flares and relapses in majority of patients. So if we look at the key trials in induction in GPN and microscopic polyangiitis, the Cyclops trial showed that IV cyclophosphamide is non-inferior to oral and is associated with lower cumulative dose, and therefore this replaced the oral cyclophosphamide prolonged treatment during the induction. On the other hand, rituximab was found to be non-inferior to cyclophosphamide, but was found to be better for relapsing disease, having similar kind of relapse rate. Rituximab showed that the outcomes were similar with the use of rituximab, and the MIPEX trial showed that plasma exchanges were superior to methylprednisolone alone for dialysis independence at 3 months and 12 months. And this was then followed by the PEXIVAS trial, where they tried to look at its efficacy in terms of effect on the mortality as well as the end-stage kidney disease. And I'll be discussing the PEXIVAS trial in more detail. MYCYC trial that looked at mycophenolate versus IV cyclophosphamide showed that there were more relapses in mycophenolate. So while rituximab was found to be non-inferior to cyclophosphamide, and plasma exchanges in the initial trials are found to be beneficial for improving renal survival at 12 months. They also mentioned that there was a need to reduce the corticosteroid dose to prevent serious infection in adult patients. So this was a very large trial that compared plasma exchange in severe ANCA vasculitis versus no plasma exchange, and standard therapy was in the form of either cyclophosphamide or rituximab, and majority of patients received IV cyclophosphamide. And these are patients who had severe ANCA vasculitis with an eGFR of less than 15 ml per minute. The primary outcome was death or end-stage kidney disease at a follow-up ranging from 2 to 7 years. And this trial also had a 2x2 factorial design, wherein low-dose corticosteroids versus the standard-dose corticosteroids were also tested in the two limbs. So what this trial showed was that the plasma exchange versus no plasma exchange there was no difference in the outcome of death or end-stage kidney disease. And on the other hand, you could see that there was again no difference between the reduced dose and the standard dose. The reduced dose was 50% of the standard dose, and it met the non-inferiority for the reduced dose. So they concluded that PEX did not reduce the outcome of death or end-stage kidney disease. However, they found that low reduced dose corticosteroids are non-inferior and could be used in induction treatment. So once this trial was out, then they tried to do a meta-analysis with the previous existing plasma exchange trials. And when combining all the data of the 9 randomized control trial, they looked at the outcome at 12 months. So the PEXIVAS looked at the outcome at 2 to 7 years. When they in the meta-analysis looked at the outcomes at 12 months, which the MIPEX trial did, what they found was, while there was no effect on the mortality, there was a significant reduction in the end-stage kidney disease at 12 months. So it does appear that it has a benefit in terms of reducing the dialysis dependence at 12 months. But they also showed that in this meta-analysis that while the risk of end-stage kidney disease is reduced, there is increase in serious infections at 12 months. So there was a criticism of the PEXIVAS trial that it included patients in relapse, and these patients didn't undergo a renal biopsy. So possibly there were more patients with already chronic sclerosis which were enrolled, and that's why the effect of plasmapheresis was not seen. It was also underpowered for severe renal involvement and dialysis. So this is still a relevant question, that if you have a patient who is presenting with dialysis and is dialysis dependent, whether plasma exchange would be beneficial. And again, for the diffuse alveolar hemorrhage, again, it showed no difference in terms of mortality. And that was perhaps again because the DH, for this outcome, again, the trial was underpowered. So the meta-analysis also interestingly showed that there was an incremental benefit with increasing serum creatinine in renal survival at 12 months. So based on the Pexivas trial and the meta-analysis, the KDIGO and EULAR, they suggested a practice point to consider plasma exchange if serum creatinine is more than 3.4 with active nephritis. Also to consider doing plasma exchange with diffuse alveolar hemorrhage with hypoxemia, or if there is a double positivity with the anti-GBM disease. And there is a need for future trial to address the role of plasma exchange in severe renal disease, which is dialysis dependent. This was a study which tried to look at whether can we reduce the dose of steroids. And we heard Kim speaking about reducing the dose of corticosteroids in lupus nephritis. And this study from Japan in a randomized controlled trial showed that with the reduced dose regimen, which is half the standard dose, they were able to achieve similar kind of remission rates. And they were able to show the non-inferiority of the reduced dose corticosteroid as opposed to the standard dose. Now, the other treatment that has been examined in the last couple of years has been avacopan for the treatment of ANCA vasculitis. And this is a C5a receptor and blocker. And this phase 3 trial, which included 331 patients, wherein patients received in standard induction with either rituximab or cyclophosphamide. And they were one group received avacopan twice daily for a period of a year. And in the other group, the prednisolone therapy was rapidly tapered. And they found they found was that avacopan was non-inferior to prednisolone taper. So it can be used as a steroid sparing agent when we can reduce the dose of steroids. And at the same time, they also found that the avacopan group patients had a superior outcome at 52 weeks. Now, the part of this was the advocate trial, and another analysis of the advocate trial, they did a subgroup analysis in those patients who received rituximab and avacopan, called the advocate 2 or whatever. And they showed that in these 214 patients who received rituximab and avacopan, the patients who received avacopan had a better EGFR change from baseline at 52 weeks, and also there was a faster recovery in proteinuria. So about the guideline for treatment of ANCA vasculitis, this is the KDIGO's statements which say that steroids with cyclophosphamide or rituximab be used as initial treatment of new onset ANCA vasculitis. If there is a rapidly declining GFR or with a serum creatinine of more than 4, cyclophosphamide and glucocorticoids are preferred. So better not use rituximab in these kind of patients because there is limited data to support the efficacy of rituximab. Plasma exchange should be considered when the serum creatinine is more than 3.4, diffuse alveolar hemorrhage, or there is an anti-GBM disease. And you can also use a combination of cyclophosphamide with rituximab. So either you use 4 doses of rituximab and combine it with IV cyclophosphamide 2 doses, or you use 2 doses of rituximab and 6 doses of 500 milligram fixed dose of cyclophosphamide. So this is in an algorithm, a summary of how induction should be done. If there is no organ-threatening involvement, you could use either rituximab or cyclophosphamide. When there is an organ-threatening or serum creatinine is high, consider plasma exchange and consider either IV cyclophosphamide or a combination of rituximab and cyclophosphamide. Now, about the maintenance therapy in GPA, these are the various trials that have compared cyclophosphamide with azathioprine with mycophenolate versus azathioprine. And in fact, there were more relapses in mycophenolate as opposed to in lupus, where mycophenolate is more effective treatment for maintenance. In vasculitis, in ANCA vasculitis, somehow there were more relapses. And the REMAIN trial showed that, in fact, longer the treatment for ANCA vasculitis, lesser are the relapses. So they suggested prolonging the treatment from 24 months to 48 months. So consider treating these patients for 2 to 4 years rather than a short treatment up to 2 years. Then what is the role of rituximab in the maintenance or therapy in granulomatous polyangiitis and microscopic polyangiitis? The first trial was the main RITSEN trial, which looked at rituximab given at 6-monthly interval versus azathioprine, and it showed that it was rituximab was better than azathioprine at 28 months. And this was then followed by MINRITSEN-2 and MINRITSEN-3. MINRITSEN-2 trial was to look at the dosing schedule of rituximab. There were two kinds of dosing schedule which were used. One was the fixed one every 6 months. The other was the rituximab given when there was a B cell recovery or return of the ANCA. And what it showed was both of them were similar in terms of efficacy, in terms of relapse rate. However, the tailored arm received fewer infusion. Now, as a part of the MINRITSEN-3, what they did was they randomized patients who were in MINRITSEN-2 to continue on rituximab further for another 28 months versus placebo. And what they found was if rituximab was given even further, for further 28 months, the relapses were much lower to 96% versus 74% in sustained remission in placebo. So extended therapy with 6-monthly rituximab lowered relapse rates with no increase in side effects. They finally ended up pooling all the data of all patients on MINRITSEN trials and showed that the 84-month relapse rate was much better in rituximab as opposed to azathioprine. Then about the maintenance therapy, this is another key trial, which is RITA-ZAREM trial, which compared rituximab with azathioprine in relapsing disease. 170 patients randomized, and they looked at 4 doses of rituximab versus azathioprine continued for 24 months. And the steroids were at inclusion were kept at a very low of 10 milligram per day. And what they showed was that the relapses, relapse-free survival probability was 85% versus 62% in azathioprine. So relapses were seen in 15% while on therapy and azathioprine 38%. And when they stopped the treatment, the relapses reappeared. So you could see that relapses were as high as 45% in rituximab and 71% in azathioprine. So there is a need that the relapses even continue to happen even after you have given a very prolonged maintenance therapy with rituximab. Now, this is the new agent belimumab, which has also been tried versus azathioprine for maintenance. However, it failed to show a benefit when it was added on to the azathioprine-based maintenance regimen. So for the maintenance, KDIGO recommends that either rituximab or azathioprine can be used with low-dose corticosteroids, and the optimal duration can be longer, 18 months to 4 years. And for refractory disease, the guidance says that you can either use cyclophosphamide or rituximab if it was not used previously. Now, there are various new therapeutic targets which are, you could see from the pathogenesis of ANCA vasculitis in this diagram, where people are now trying combination of belimumab with rituximab. Obinutuzumab has been also tried. There is an ongoing trial with the abatacept, and certainly similarly there are trials with monoclonal antibodies in the EGPA. So to summarize, therapy is largely extrapolated from adults in ANCA vasculitis and crescentic glomerulonephritis. Corticosteroids and IV cyclophosphamide are key therapies in severe ANCA-associated vasculitis. Rituximab is a good alternative induction agent in relapsing disease and in non-severe renal disease. Plasma exchange still has a role in severe nephritis and hemorrhage, pulmonary hemorrhage. Corticosteroid reduction is feasible. You could either add on avacopan, which is also a promising induction agent, and prolonged maintenance can be done with rituximab with little side effects. And there are ongoing trials with novel targets to find out new drugs for this condition, which still has a lot of relapses and has a risk of going into end-stage kidney failure. So I'll stop here. Thank you very much.
Thank you, sir, for an excellent presentation. Now, if there are any questions to sir, please ask.
Do you have any comment on using IV rituximab together with mycophenolate and steroids for induction in ANCA-positive cases?
No, we haven't used it, but I also didn't find any kind of a study which combined mycophenolate for induction with the rituximab. Because they're still worried about rituximab and this kind of a combination may still not be very good for ANCA vasculitis. It does say that you can combine cyclophosphamide with rituximab, but not mycophenolate. Yeah, because I mean, for severe disease, KDIGO still recommends IV cyclophosphamide than rituximab. But it also mentions that if you want to reduce the cyclophosphamide dosing, you can add it with the rituximab.
If there are no further questions, then we can close Dr. Pankaj Hari's session.
Thank you.
And for the next session, the speaker is Dr. Marina Vivrali, and she is the Chief of Pediatric Nephrology at Bambino Gesù Children's Hospital at Rome, Italy. And she was the chairperson and also the lead author of the IgA nephropathy clinical practice recommendations that were published by IPNA this year. So, ma'am, please.
Good afternoon. So here I am again. So this is really a presentation of a group effort, a massive group effort, I must say. Some of the people in this room also participated. And I'm going to focus on IgA nephropathy. Dr. Sina asked me to put in 3 or 4 slides to talk about vasculitis as well with nephritis, but I will really just highlight a couple of concepts for that. And these slides that I will present were actually prepared by Dr. Arifa Aladdin, who works in Canada and who was part of the evidence review team for this guideline. And so she prepared these as a template for the IPNA Best Practice and Standards Committee. So just to start, this is the manuscript citation. So you can find everything here. It's already published. It's been published for a while. So I'm going to skim through the things that, you can just go and read on the publication and try to sort of tell you about the rationale that went behind the preparation of these guidelines that were made difficult, as often happens in pediatrics, unfortunately, by the lack of high quality evidence. So just as an outline, when we're thinking about how we do these things, there's a rationale. So we choose, actually the IPNA Best Practices Committee chooses focus for clinical practice recommendation manuscript. Then there's a method, which is a standardized method, which is again following guidelines that are established by this committee. And we give some definitions. And for IgA nephropathy, we then provided guidance on diagnosis, treatment, and follow-up. The rationale for this guideline, so the reason for focusing on IgA nephropathy was that IgA nephropathy is the most common primary glomerulonephritis in the world. Its annual incidence in children is 0.2 per 100,000 with a median age of presentation of 10.9 years. We know that the disease characteristics are very variable, both in frequency and in severity, depending on the geography. Also because in some countries, in particular in Japan, there are urinary screening programs that make the early detection of this disease much more frequent and therefore make its clinical course very different. There's also a very, very substantial practice variation in how this disease is managed in different parts of the world. We know that it's a leading cause of chronic kidney disease and of kidney failure, with up to 50% of children progressing to kidney failure after 30 years of follow-up. So just to sort of go back to, we spoke about nephrotic syndrome this morning. I think we spend a lot more time worrying about nephrotic syndrome in our clinic than we do about IgA. But children with steroid-sensitive nephrotic syndrome never go to CKD. Children with IgA nephropathy have a high risk of going there, but you won't see it because it'll happen 30 years later. So you should probably think about this when you're dealing with these patients, because I think at least I tended to underestimate a little bit the impact of the decisions that we take in the clinic day by day on these patients, because they're so indolent. It's such a difficult disease to get excited about. They come in with this very, very unimpressive phenotype. These are not sick kids by any means. But the bottom line is these are the kids that are going to require dialysis as adults. So the aim of guideline recommendations is to optimize care, to reduce harm, and to decrease practice variation. And with this guideline, we were particularly in the soup as far as this part was concerned, because truly it was unbelievable how everyone in the planet that was called in does completely different things based on zero evidence, but is very strongly attached to the way in which they are doing things and very adamant about not changing. So we hope that for the best or worse, we will manage in some way to give some indications of trying to follow common sense and decrease practice variation. It is, though, the reason for which, unfortunately, this is not truly a very satisfactory guideline from this point of view, because we leave a lot open to interpretation. The methodology was the standard methodology, so the right statement for clinical practice recommendations. We had a core group with 27 members, including patient partners. We prepared PICO questions, 7 for IgA nephropathy and 5 for IgA vasculitis with nephritis. We drafted recommendations for each PICO question developed by this core group of 27 members. And we gave a grading to each statement of either recommendation or suggestion, with then a grading number according to the guidelines of the American Academy of Pediatrics, which I'll show you in the next slide. Then we went out to an expert voting panel. We used a Delphi method. We needed to have a level of agreement set at equal or above 70% for acceptance. Things that did not, recommendations or statements that did not reach this were re-evaluated by the core group, modified, re-voted again, until for everything we had at least or above 70%. And I must say, by the end, we had close to 90% for almost everything. It was then reviewed by a panel of external experts from all the different regional societies all over the world, who gave a lot of really useful insight. And we had to go through another Delphi process after them. And to tell you the truth, we went through another Delphi process after the comments from the reviewers by pediatric nephrology came back. So it was a challenging process. The methodology for grading the recommendations was the American Academy of Pediatrics one. So you go on the level of the quality of the evidence. In this, we were very lucky because the evidence review team from Canada, led by Susan Samuel, was preparing the Cochrane systematic review at the same time. So the level of evidence and the tables that they prepared were very, very well done. And they were really helpful in keeping us steady on the fact that we couldn't get too excited about saying something when the quality of the evidence was really, really low. And so in keeping the levels of how we graded these recommendations congruent with what the actual evidence was. So let's start with definitions of IgA nephropathy. So as you know, IgA nephropathy is diagnosed with a kidney biopsy. And in the kidney biopsy, you have to see dominant or co-dominant IgA glomerular deposits, which can be mesangial or mesangial plus capillary wall. And this needs to be added on to the exclusion of differential diagnosis on clinical and or on pathological grounds. So again, as I showed you with the, as I sort of said in my introduction, we know that this disease is not a particularly benign disease. We know that in children it tends to be slightly more benign, but it's not a benign disease in any of these two periods of life, even though it takes a very, very long time for this to become evident. And what happened was that the RADAR study, which was published while we were working on the guideline, really drove home one of the concepts that we had been working around, which was the fact that we need to be very ambitious with these kids and not be complacent on, oh, they have less than half a gram of proteinuria. That's okay. It's not okay. And this was driven home very strongly by this study, which was very, very important, because it showed that even in the higher echelon, which is 0 to 0.44 gram over gram, so a urinary protein to creatinine ratio, which really wouldn't raise any eyebrows, over 15 years, your EGFR goes substantially down, and your risk of going into terminal kidney failure substantially increases. So we have to go to below 0.2 to be happy in our patients, especially because we're treating children who have decades and decades of life before them. oops, sorry, I'm going backwards. I was like, what's going on? Okay, so this was important. So this drove our definitions. We decided to be ambitious in the definitions, and we defined remission as resolution of proteinuria for at least 1 month. By resolution, we mean UPCR below 0.2 milligrams over milligrams or 20 milligrams over millimole, and I think this will be now clear why. Plus, they have to have normal or stable GFR above 90 whenever possible. Plus, they need to be with a complete remission. Also, they need to have resolution of hematuria. This was recognized by a number of studies that showed that even having only hematuria, isolated hematuria in the absence of proteinuria, indicates that if you do a biopsy on that patient, which is not very likely, but it has been done in adults, you will see a certain degree of activity in some cases. So again, we're treating a silent killer. We have to be ambitious. We want to get rid of the hematuria in addition to stabilizing the eGFR, in addition to getting the proteinuria to 0.2 or below. When this is achieved, we can think about how we define relapse. And so we defined relapse, a patient who previously had achieved remission, and then in whom we have reappearance of proteinuria on 2 urine samples, 1 to 2 weeks apart. In addition, this patient will most likely also have hematuria and or a reduced eGFR below 90 or a more than 25% reduction from baseline. The definition of recurrence, so of a IgA reappearing on a transplanted kidney, was given when based on the biopsy. So when we have glomerular IgA deposits in a patient with a history of IgA nephropathy or IgA vasculitis with nephritis on his or her native kidney. As you know, hematuria, proteinuria in the setting of a post-transplant can be very tricky and have a whole variety of differentials, which is even more complicated and may lead us in different positions. So in terms of assessment and diagnosis, so we have a patient coming in and we need to assess him or her to understand whether or not he has IgA nephropathy. So we need to take a careful patient history. We need to check for both kidney and systemic manifestations, a detailed physical examination and blood and urine tests. And there's a table which is very detailed with everything that needs to be done and the timing. What is important to do is to exclude IgA vasculitis, to exclude secondary causes of IgA nephropathy, which, to be, fair, are very rare in kids, especially liver disease or viral illnesses less. And the other ones that are less rare in children are the concomitants of an IgA picture with inflammatory bowel disease. And then we need to exclude, and this can be very tricky, it was useful to hear the talks earlier today, the infection-related and the post-infectious GN forms. And for this, the biopsy is absolutely key. In terms of urinary tests, we need to quantify proteinuria, document hematuria. If the children are a little bit older, we need to exclude orthostatic proteinuria. And then we need to calculate the GFR using, as by recommendations, the modified Schwartz formula for children. So the table with the initial assessments, I'm not going to go through it in detail because it's all published. But the idea is to, look for anything that may make you think that it's an atypical picture, it can be something different. Check for the important infections, especially tuberculosis in endemic areas, HIV, hepatitis. Think about inflammatory bowel disease, other autoimmune diseases. So look if the patient has any systemic symptoms in addition to the urinalysis abnormalities for which he or she is arriving. When you examine the patient, search for signs of edema, steroid-toxicity, extrarenal features, rashes, oral ulcers, joint swelling, pubertal status, vital parameters, blood pressure, height and weight, and BMI. The urine you have to check at least once with a proper urinalysis because you need to detect carefully both the urine protein creatinine ratio and the presence and morphology whenever possible of the erythrocytes. Regular routine blood exams. We went a little bit more in detail. Thyroid function only if they have nephrotic range proteinuria. C3 can be important to do at diagnosis together with IgA levels, but not necessary to do further down the line. And infectious screening and autoantibodies as appropriate based on for the first, whether or not you're thinking of giving glucocorticoids, and for the anti-autoimmune antibodies, if there's anything that makes you think that that might be a differential diagnosis. The renal ultrasound at presentation, especially because if there's hematuria, you can think about urological differential diagnoses, and then it's considered mandatory before performing a kidney biopsy. Ultrasound of the abdomen if the patient is nephrotic, cardiac ultrasound only if there's severe edema or hypertension, chest x-ray only if indicated. In terms of histopathology, the renal biopsy is absolutely required to perform a diagnosis of IgA nephropathy. This is very important. And then it's very important, once you have the diagnosis, to get the dietitian on board, because we know that appropriate intake of sodium is key to control well this disease. So in terms of diagnosis, the key point is a kidney biopsy is required for the diagnosis. So we can't say IgA nephropathy unless we've done a kidney biopsy and we've looked at it. So when to perform the kidney biopsy? So this is a little bit more tricky. It was easy to recommend, considering the possibility of primary IgN, and therefore to consider a biopsy if there's hematuria with proteinuria that is significant and persisting over 2 to 3 weeks and at least 2 clear urine measurements, having eliminated lower urinary tract etiologies or features of systemic disease, and when normal serum C3 levels are present. We suggested to consider this if the patient has, in addition to this, persistent or recurrent gross hematuria with an upper respiratory tract infection, what is called synpharyngitic hematuria. And we know that this is a classical presentation of IgA nephropathy in children. However, it can be present in, for example, post or intra-infectious forms of GN as well. We recommended to perform a biopsy promptly if, in addition to the hematuria that is persistent or recurrent, there's nephrotic range proteinuria or reduced eGFR. That's pretty obvious. We recommended to perform it also if the proteinuria is significant, above 0.5, and at least 2 measurements 1 to 2 weeks apart. We suggested, so we gave a lower grade, if there's hematuria with a proteinuria that is only between 0.2 and 0.5 in at least 3 measurements. So we tried to give a grading because we didn't want these patients to be jumped upon, but at the same time, we didn't want a patient to sit around with urinary abnormalities for too long before receiving a kidney biopsy. And the bottom line is, if the patient has a normal blood pressure, normal platelets, and 2 kidneys, it's more important to have a diagnosis than not to remain with a risk. So get on with it, do your biopsy, have your diagnosis, and proceed. This is just the flow chart telling us what to do. At the same time as when we're thinking and planning a biopsy, we can start RAS blockade. The earlier, the better. It's been known to be important and protective for any form of proteinuria. What are the major differential diagnoses? So this is important because, especially in children, it can be a consideration that is sometimes a little bit not thought about. So we know that, okay, I'll start from the bottom: ANCA-associated vasculitis, IgA vasculitis with nephritis, lupus. All of these are going to have systemic symptoms. The post-infectious GN is really tricky, and sometimes we just really need to perform a biopsy to have the result. But luckily here, the biopsy will definitely help us. The ones that are a little bit more difficult, and we really need to think about them carefully, are the forms of thin basement membrane disease and of Alport syndrome. So the genetic forms that can give alterations that are phenotypically very similar with hematuria and low-grade proteinuria. So there we need to take an accurate family history. And we need to sort of think about, in those cases, whether it's more indicated to perform directly genetic testing rather than performing a kidney biopsy, also depending on the time of turnover for this type of testing that is available in each specific center. But it's definitely something that we need to be aware about. As you know, the biopsy, once performed, is scored for IgA nephropathy by the Oxford MES-C score. MES-C stands for M, mesangial hypercellularity, and the score that is given is M0 or M1. The E stands for endocapillary hypercellularity, E0, E1. The S for segmental glomerulosclerosis, and it can be S0 or S1. The T for tubular atrophy, and it has 3 grades, T0, T1, and T2. T2 is above 50%. And then the C stands for cellular crescents. And also this can be C0, C1, and C2. These are some representative images of the different scores, courtesy of Professor Haas. And with this, we move on to what we do for monitoring and follow-up. So one of the things that we wanted to be sure would happen, and I think with what I've told you, it's going to be obvious why, is to really keep on following up these children, even if they look as if they were doing pretty well, and even if they have achieved the stringent definition of complete remission that we gave. We decided after careful consideration that they need to be followed up long-term. We actually recommended following them up, pretty much lifetime, because they can relapse even after many, many years. So at least once a year that someone should give them a look at their exams. We also recommended, of course, adjusting the follow-up intervals based on the severity of the clinical symptoms, the features of the kidney biopsy, the treatment regimen, and the treatment response. Common sense. And we suggested to reevaluate the etiology to exclude secondary forms if after 3 to 6 months of supportive treatment, no improvement was seen. So yes, lifelong yearly monitoring of blood pressure and urinalysis for patients with a history of pediatric IgA nephropathy. This is important even when we're doing transition. And upon diagnosis, since this is a long haul thing that the patients and their families are entering, we recommended offering psychological and social support on a case-by-case basis. In terms of management, so let's start with some clinical vignettes. So we have a little girl, 9 years old, diagnosed with IgA nephropathy by kidney biopsy. She has M1 on her MESC score. Everything else is negative. Her urinary PCR is 78 milligrams per millimole. She has microhematuria, 35 red blood cells per high power field, and normal serum creatinine. This is what her biopsy looks like. So, there's the mesangial proliferation and the intense IgA and nothing else. So how would you treat this type of patient? So in the group that we were, that we had put together of experts from all over the world, for 27 experts, we got 27 different answers. So there's no right answer, unfortunately. So we tried to, go by steps. So first of all, in patients that have significant, and we put the threshold low, even if it's 0.2, it has to be below 0.2 to not do anything. You start by optimizing supportive care. There is a lot of evidence that supportive care is really helpful in this disease specifically. The dietary counseling to moderate the salt intake is really important. Starting a RAS blockade, either an ACE inhibitor or an angiotensin receptor blocker earlier, and going to maximally tolerated doses is important. And again, we have to aim to go to complete negativization of the proteinuria. Maintaining blood pressure aggressively within normal values, and in CKD stage 2 or higher, even lower than normal values. Again, because we have to think about really maintaining that glomerular filtration pressure low and keeping the glomerulus happy, because it has to stay happy for a long time. In addition to this, regular aerobic exercise and counseling parents and children on the increased risk of kidney disease progression in people who are overweight and obese, and so giving nutritional counseling when available. If the situation is benign, we did not feel that we could introduce any specific treatment other than this in the beginning, and we recommended to regularly reevaluate these patients. So obviously, then the very thorny issue of when and how to start steroids and glucocorticoids in these children was raised. And we all know that compared to what is done in adults, we tend to be much more proactive in using glucocorticoids in these children. And I think overall, we are right to do this. And the rationale for doing this is that due to the fact that children present with macrohematuria, they have a much more rapidly, the diagnosis is made much sooner compared to adults. We have a lot more of inflammation that we can work on with glucocorticoids. However, when we look at the data from randomized controlled trials, scant and inconclusive, and when we look at the retrospective data, often not very convincing that we're actually doing something in the long run. In the short follow-up, it's obviously working, but in the long run, the evidence that giving even pretty prolonged courses of glucocorticoids is actually changing something for our patients is very, very low quality, almost non-existent. So sometimes it's almost more something that the doctor is doing to feel better rather than making the patient feel better. So we have to be a little careful. And I'm one of the, I was one of the people who tends to use glucocorticoids a lot. I come from a group where we use them a lot. But I must say that doing this guideline really made me kind of aware of the fact that sometimes you just do things automatically without giving it too much thought. So in the end, after some pretty bloody discussions, we did not recommend the use routinely of glucocorticoids. And, we tried to be very sort of ecumenical and to include every opinion. So we ended up writing that we suggest considering treatment with steroids in selected settings based on risk assessment. So based on our assessment of the risk, a clinical risk of progression, child per child. We did recommend, to start with the RAS blockade, and we said, okay, if you have a UPCR between 0.5 and 1, despite 3 to 6 months of RAS blockade, or if you have a UPCR above 1, despite 4 weeks of RAS blockade. But we also put, if you have a MES score, because we recognize the fact that there isn't a whole lot of evidence for the MES score being important, but come on, it has to be important because the kidney biopsy obviously is telling you what's going on in that kidney. So if you have one or more of the following scores, either M1, E1, or S1 with podocyte lesions, or C1, and your UPCR is consistently above 1, then you would consider starting treatment with steroids. In this way, and what I wanted you to sort of see is that in this way, with the last statement, statement C, is a condition in which, we're saying you can start it right away, but you should start it right away if the UPCR is at least 1. I honestly am not convinced that 4 weeks of RAS blockade are going to be seriously endangering a patient. I mean, it's probably the time that it takes you to get your lab report from the kidney biopsy, quite honestly, if you're up on it and you start it right away. The 3 to 6 months is more debatable. We personally don't do that in Rome, but we're talking about a UPCR between 0.5 and 1. So I'm walking you through this carefully because it was so contentious to actually write these words down, and because it's not what I do in my clinical practice, so it was painful for me as well. But to tell you the truth, I probably think that this is the most sort of balanced way of dealing with these patients now that I've looked at the evidence really carefully. So when you give steroids, what do? You give a 4 to 6 month course of glucocorticoids you should consider. If you're giving it oral, you could use the same dose that you use for nephrotic syndrome, so 2 milligrams per kilogram per day with a maximum of 60. And then you taper after 4 weeks, and there's no idea of how you should taper. So we just said you alternate day, go down to interrupt it over 5 to 6 months. It can be useful in sometimes to extend it further, and lower doses may be useful from data that has emerged from the adults. If you prefer to pulse, we follow the so-called POTSI protocol, so 3 methylprednisolone IV pulses, 15 milligrams per kilogram day, over 3 consecutive or alternate days, and then you follow with oral prednisone or prednisolone, or you can give only the boli at 3 times at 2 months intervals. So this is just, based on old evidence that was published in adults. So, but we also wrote, okay, we have to consider the risk-benefit balance of glucocorticoid side effects in these children, since given the fact that the evidence for the use of glucocorticoids is so scanty. In selected cases, we did write that the use of glucocorticoids can be considered concomitantly with RAS blockade, so right from the start, if there's nephrotic range proteinuria, reduced eGFR, and crescentic or actively inflamed findings on the histology. We also said to consider avoiding glucocorticoids if the tubulointerstitial scarring is more than 50% in the absence of active lesions. So this is unfortunately unlikely to happen in children, but sometimes it does happen. And the target, again, is to be ambitious and to go down with her proteinuria below 0.2. If there's no response within 3 to 6 months, you consider rebiopsy and modifying treatment. In terms of other immunosuppressant, complete nightmare. We had to write, we suggest considering the use of additional immunosuppressive drugs in combination with glucocorticoids in selected settings, because there's really no evidence for classical IgA nephropathy to what to do. So it's easier in some selected settings that I'm going to talk to you about now. And this is all schematized in this schema, but this is one of the guidelines for which I really feel strongly that the algorithms need to be accompanied by a very careful and mindful reading of the text, because if you just look at the algorithm, you can really be sort of led down the garden path. The other thing that I always show, and it did inform our algorithm because we were very sort of adamant about, if in doubt and if what you're doing is not working, consider a clinical trial. There are a lot of drugs coming through the pipeline for this disease, drugs that are antiproteinuric agents, drugs that target complement, and drugs that target the B cell dysregulation that underlies IgA nephropathy. It is really important that we try to get high quality data, even in children, with all of these agents. So if in any way possible to do it in a controlled fashion, try to get your patient into a study and to try something innovative. In terms of supportive care, vitamin D, follow international guidelines, immunizations, follow national guidelines, fish oil, not recommended, tonsillectomy, not recommended. Also there was a lot of debate, especially for the tonsillectomy, but in the end, we decided that we didn't feel that it was strong enough to recommend it. So let's look at a couple of clinical vignettes. Clinical vignette number 2. G is a little boy. He's 13 years old. He has an onset of nephrotic syndrome. So he has nephrotic range proteinuria. His serum albumin is 2, but he's got microhematuria. But that happens sometimes in nephrotic syndrome. Anyhow, that's what he has. He has normal serum creatinine. He does a kidney biopsy because he's 13, because otherwise he would have just received for, 6 weeks plus 6 weeks. And it shows positive IgA by immunofluorescence, but the MES score is completely negative. M0, C0, E0, S0, C0. So that means that he has a minimal change disease. So this is a minimal change disease by light microscopy with a positive IgA by immunofluorescence. So this is one of the atypical forms that we need to be aware of, because these forms are children who present with nephrotic syndrome. They have minimal change disease, but they also have associated IgA deposition. So what you should do? You should ignore the associated IgA deposition. Go to the guideline, which Christoph Licht forgot to mention earlier, that we produced for steroid-sensitive nephrotic syndrome with IPNA, and follow that guideline. This child has minimal change disease, steroid-sensitive nephrotic syndrome. Forget about the IgA. The IgA is just something that you find in the biopsy, but it doesn't mean anything. This is very important because it's not as infrequent as you would think. Clinical vignette number 3 is a little boy, again, male, 10 years old, with onset of nephrotic syndrome. Again, nephrotic range proteinuria. Again, low serum albumin. Yes, sorry, I was worried that I had done a mistake. No. Microhematuria, so identical to the first one. However, this boy's serum creatinine increases rapidly in 72 hours from 44, so 0.5 milligrams per deciliter, to 185, so 2.1 milligrams per deciliter. So here, what are you thinking? This is a rapidly progressive form by definition. So as Pankaj Hari mentioned before, rapidly progressive, you treat them all in the same way. It doesn't matter if it's IgA, doesn't matter if it's C3, doesn't matter if it's lupus, whatever it is, if it's ANCA, whatever it is, you treat it in the same way. So you perform a kidney biopsy, and here you find in the MES score C2, but this is an IgA nephropathy, M1, E1, and you have the immunofluorescence, which is typical. But here, it doesn't matter. What is more important is the clinical presentation of the rapidly progressive and the fact that there's C2, so there's a lot of crescents. These patients need to be aggressively treated, as all patients, adults and children, are treated if they have a rapidly progressive form. So you give IV glucocorticoids plus other intense immunosuppressive antiproliferative agents such as cyclophosphamide, or you could consider giving mycophenolate. So the definition of remission is another concept that, no, I already talked to you about this. Yes, sorry. So what do we do in case of relapse? Oh no, so here, what I wanted to underline, I put it again because I just wanted to underline that for remission, we don't only consider the proteinuria, we consider the proteinuria, the GFR, and the hematuria, and I think that's very important to keep in mind. So a relapse in a patient who has previously achieved remission, how do we treat it? Optimal conservative treatment, and then the whole kit and caboodle that you did the first time. There's nothing new, there's nothing different, you just restart the cycle, unfortunately. And when should you discontinue? We suggest discontinuing immunosuppressive treatment in children who did achieve a full remission for at least 12 months. We suggest continuing supportive therapy with RAS blockade and lifelong monitoring, and we individualize that according to the severity and response to treatment. So it's difficult to say when to interrupt a RAS blockade. I would tend to be quite conservative and keep it on, especially if the initial presentation has been severe. We know that it's rhinoprotective. If it's well tolerated, it's probably helpful. But, I mean, after like 3 years, I would probably consider starting to remove it if the patient is doing really well. So post-transplant recurrence, again, the diagnosis is made based on the biopsy and not based on the clinical presentation. The recommendations are to optimize supportive care, suggest maximal RAS blockade, and not implement the glucocorticoid withdrawal that you would normally do in a transplanted patient. And again, enroll in clinical trials if at all possible, and the same treatment options as per initial treatment. I really think that this drives home the fact that we need better evidence in these children to drive our treatment and make it a little bit more solid. I don't know if we have time for IgA vasculitis nephritis because we're already a little bit over time. So tell me if I only have like 3 slides. Okay, so for IgA vasculitis nephritis, I just wanted to drive home a couple of concepts. So first of all, here, the diagnosis is much easier because you have the systemic features. So the purpura is pretty easy to diagnose. It's pretty classic. If you've seen it once, you'll, recognize it for the rest of your life. So in those patients, when you have the IgA vasculitis, you have to aggressively look for the renal involvement because it's often there. It can be very obvious, but it also can be quite subtle. So these patients have to perform urinalysis screening. In the guideline, we write exactly for how long and how often, blah, 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 blah. But you have to remember to really do that carefully and judiciously for at least a year after the initial presentation of the skin and the rest of the systemic manifestations. So in terms of when to do a renal biopsy, it's a little bit sketchier here. You can reasonably have a pretty 99.999% conviction of your diagnosis without performing a kidney biopsy. On the other hand, the biopsy will really help you guiding the length and the intensity of treatment, especially with glucocorticoids. And this is important because often these patients have already received glucocorticoids for the systemic manifestations. So if you're in doubt, it's always better to give a look and decide based on what you see. These patients tend, at variance with IgA nephropathy children, to respond more quickly even when they have an aggressive presentation. So what we put was that it's recommended if there's nephrotic range proteinuria, okay. And it's also recommended if the EGFR is below 90, irrespective of proteinuria level. It's suggested if the proteinuria is between 1 and 2 for 2 to 4 weeks, or if the proteinuria is lower for more than 4 weeks. And this means despite you're doing what you need to do to get the patient treated. So you've already started your RAS blockade, and he or she is probably receiving glucocorticoids anyhow because of the systemic manifestations. If that situation is not evolving in a positive way, then it's better to go look and see if you need to do something more or something different. This is again mirrored in a diagnostic flow chart. There's a treatment flow chart, is very similar to the other one. And in terms of management, the only difference is that here, instead of the MES-C score, we're still driven by the ISKDC. In reality, now the MES score has just recently been validated also for IgA vasculitis and nephritis, but we didn't get it in time to incorporate it into these guidelines. And the RAS blockade, okay. And the repeat kidney biopsy, if proteinuria persists for more than 4 weeks, that was already mentioned before. Treatment discontinuation, we put a much briefer period, 8 to 12 weeks, exactly for what I was telling you, that these patients tend to respond more brilliantly, more quickly than patients with IgA nephropathy. Follow-up, even here, we hammered the idea of the lifelong monitoring because we really didn't want patients to be forgotten. If they've had an IgA vasculitis with nephritis, however slight, they do have a consistent risk of relapsing even many, many years later, and they can have slight abnormalities that give them elevated blood pressure and proteinuria down the line. With this, I finish. This is just part of the colleagues that helped us in this major endeavor, and the IgA Guideline Committee, the IgA Nephropathy Foundation, the patient associations, the ASPN, the AFPNA, the DEAL Project, and all the IPNA regional societies. This is really a group effort. Thank you so much for your attention.
Thank you, Dr. Marina, for a lucid presentation. And now if you have any questions to Dr. Marina.
Thank you, Dr. Marina. That was an excellent presentation. And one doubt that is to be cleared is there any role for targeted release budesonide in children?
Yeah, so that was one of the things that we wished had been assessed in a more sort of structured fashion. I, had so many conversations with the company Calliditas, trying to convince them to set up a randomized controlled trial in children. It was really a shame that they never wanted to. So in the absence of that, a lot of people are doing it anyhow. We use budesonide a lot in our clinic now, rather than giving prednisone or prednisolone. We in fact use it more frequently now than prednisone or prednisolone. We don't use the formulation, the Nefecon, that was approved, because it's super expensive and it's not prescribable in children. So we use a formulation which in Italy is called Entoshir, but it's the one that is approved in Italy and I think in most countries for IBD in children. It works really well, and it does have less systemic manifestations. But glucocorticoids are all the same. As soon as you remove them, you're back to square zero. So if the patient is not controlled, if that is an active inflammatory condition, it doesn't give any, it doesn't modify the disease, the underlying disease. But especially in patients that have comorbidities that make you worried about using glucocorticoids, it's definitely, and this is mentioned in the guideline, is definitely something that can be a very attractive option.
Dose and duration?
So we ask our gastroenterology colleagues. We start depending on the body weight with so in the trial it was 16 milligrams, which for our type of formulation is 9 milligrams, the equivalent. So we start with the higher dose for a short period of time, pretty much like what you do for prednisone, not more than 4 weeks, and then we taper down. We never give it for more than 3 or 4 months.
But I would probably caution our colleagues here, that we do need trials in
Yes.
children. Please do not start using the drug without data. So be careful. I think it's okay I know the drug is available. You can use it, but there should be more data. And I think maybe the bigger centers, it's incumbent on them to kind of plan trials and do it in a prospective manner.
Yeah.
Center-wise, whatever. Christoph and Marina, what do you foresee the role of C3 blockers in the future in this disease?
Well,
Christoph.
I wish. So I can tell you something. I'm sure Christoph has something up his sleeve as well. So in terms of iptacopan, so the factor B inhibitor which has been approved for IgA nephropathy in adults, we really don't know in children because we're not allowed to use it under the age of 18, and it's only being used very tentatively in the 12 to 18-year-old range because of some safety issues that needed to be cleared. So we really don't know. The rationale is, potentially there. Again, the reduction in proteinuria was nothing to write home about, so I don't know. The other, there's C5 inhibition, so specifically ravulizumab has been looking interesting, and that makes sense in the sense of the anti-inflammatory effect in IgA vasculitis with nephritis. So I've just started one patient for compassionate use. She was a patient who had received everything under the sun because she had a very severe IgA vasculitis before developing the nephritis. So she had already received methylprednisolone boli, mycophenolate, a calcineurin inhibitor, and rituximab. And so we repulsed her with methylprednisolone boli, but we wanted to give her something different. And she has already, her GFR is about 50, and she has a proteinuria which has a chronic component, definitely. We've only started her for about 3.5 months, but her serum creatinine has gone down, and her proteinuria has gone down. So we'll see, but it's an N of 1, so. And I don't know if Christoph has any comments on that. I'd be very interested to hear them.
Well, little to add. So it's one of those really strange situations where you have a lot of evidence that complement plays a role. You have something that points towards classical pathway, mechanistically, staining-wise. There's a lot of evidence pointing towards complement, and all the trials. To be honest with you, everything I have seen is not convincing. What has been used and published and shown. The one that seems most promising in my mind, or interesting, not promising, interesting, is the lectin pathway. So that seems
But
kind
the
of
trial was discontinued for. I was also really surprised. That was for narsoplimab,
Yeah.
which blocks the leptin pathway, and we all thought that was going to be the answer, and the trial was discontinued. I don't know if you know if there was any issue with the trial specifically.
That's what I have heard, but I'm not. I don't have clear evidence for that either. But again, there's a huge gap between kind of the evidence, if you want, in quotes, pointing towards the role for complement, and the lack of effect of all the trials, since everything has been tried. I would also agree that an anti-inflammatory kind of concept might be promising, but I mean, yeah, I'm surprised by the lack of effect, basically.
Ma'am, the 13-year kid with the presented as excuse me, ma'am, this way. Ma'am, this way.
Okay.
Ma'am, the 13-year kid with presented as nephrotic syndrome, biopsy showed minimal change with IgA deposit. There was few microscopic hematuria. As per guideline, we planned for treating as minimal change only. So 6 weeks of daily steroid and 6 weeks of alternate day. So okay, sir. Okay, ma'am. So after 4 weeks of daily treatment, complete resolution of proteinuria, but RBC is still persisting. So what next? But the microscopic hematuria is persisting. Proteinuria gone, microscopic hematuria persisting. So it is now a remission or not? Because as per IgA, it is not in remission, but as per nephrotic, we are no comment on RBC. So now consider as steroid resistance or sensitive? It's
Thank you very much. We
you.
move to the last talk of this session. I invite Dr. Georgie Matthew for his talk on anti-GBM nephritis nationwide experience. Dr. Georgie is Associate Professor of Pediatric Nephrology at CMC Verror, and he's an avid photographer. He runs an Instagram site for his photographs. You can log into his site and look at the photographs. Over to Dr. Georgie.
Thank you for the kind words. So, first of all, I'd like to thank the organizing team for inviting me here. I was a student here 4.5 years ago, and now I'm working as faculty at Christian Medical College, Vellore. So, before starting my topic, which is anti-GBM nephritis and nationwide experience, I'd like to have a show of hands of how many of faculty or members have seen, diagnosed and treated anti-GBM in the last 15 or 20 years, or how many ever years of your clinical practice. Thank you so much. Yes, that was the point of the exercise. So because we are collecting some data on this, so we would invite all of you to collaborate on this data. I will tell you why we need this data on this particular condition. So, so these are standard abbreviations for any glomerular disease. So anti-GBM disease, as we all know, is a small vessel vasculitis. It is caused by antibodies against the NC1 domain of the alpha-3 chain of type 4 collagen of the GBM. The same protein is found in the alpha-3 chain type 4 collagen is found in the lung. So it affects both of them. If it's affecting both of them at the same time, we call it Goodpasture syndrome. And isolated kidney disease is common. Goodpasture disease is also common, but however, isolated lung involvement without kidney involvement is rare, and very few case reports are there. As we all know that it's a very, very rare disease. There are not even many people even in this distinguished faculty room that, all of you are well read on this disease, but, not seen patients. Underdiagnosis, underreporting, or even, missing patients may be the reasons. The pooled 1-year survival is less in this condition. Patient survival is about 76 and kidney survival is just about 30%. So it is a bad disease to start with. There is definitely reduced prevalence or incidence in children. However, the ESKD is also not uncommon in this disease at all. So just about the history, this was a physician and pathologist in the about a century ago during the influenza epidemic. He described a severe case of pulmonary renal syndrome, and antibodies were discovered in the 1950s. So that is how we know about this good posture disease. However, an important contribution to healthcare or medicine is that he invented methods for growing viruses and rickettsia in embryos, which later led to vaccine development, which is the cornerstone of most of our pediatric practice. Pathology, we know it is rapidly progressive glomerulonephritis in the syndrome, and you get crescentic glomerulonephritis, and it's a very common MCQ question, in which condition you get 100% crescents, which is anti-GBM disease, and in the immunofluorescence you will get very nice looking but potentially lethal or fatal linear IgG depositions in the glomerular capillary loops. I'm not going to delve detail into the pathogenesis and treatment pathways. You can take a moment and look at it. Maybe some of them, IgG degrading streptococcal enzyme, imlifidase, those things are coming up, but all the other treatments are standard to all other immunosuppressive care in glomerulonephritis. Moving on. This is the shortest chapter in the KDIGO guideline, chapter 11. So it just the summary statement is just 6 points, and this is the only, there is out of the 6 points, it's all practice points, and only this one is the graded evidence, 1C evidence. So cyclophosphamide and steroids with plasma exchange in all patients, except in those who have KRT at presentation, kidney replacement therapy, 100% crescents or 50% global glomerular sclerosis, and without any alveolar hemorrhage. So, which usually is very rare because the disease itself presents in a very severe manner. So, we usually give cyclophosphamide, steroids, and plasma exchange in all of our patients. Our Indian experience will present in a few slides. So, this is all ungraded evidence. Again, you may all very well know this. So, you start treatment before confirming the diagnosis. Apparently, maintenance treatment is not necessary as suggested by KDIGO. Dual antibody disease can be treated as ANCA vasculitis, and Ritex can be tried in refractory disease. Kidney transplant has to be postponed till antibodies have been negative to be at least 6 months. I try to briefly look at literature. There are very few cases or case series. There are multiple case reports. However, more than 3 patients or 5 patients case reports are very rare, and most of them show that disease is severe, is treated with all the possible things that we can throw at glomerulonephritis. And in a large cohort in the US, the Southwest Pediatric Nephrology Consortium, they found out that ESKD happens in more than 50% patients. A recent paper had mentioned rituximab for non-dialysis dependent patient, and it had a favorable outcome. There are certain variants of anti-GBM disease that you may already know. There is an atypical or antibody negative anti-GBM, the reasons to which there is a seminal paper in Kidney International written by a first author named Nasser in 2017, if I remember correctly. You can refer to that paper for further details why antibody negativity occurs because of the test or the antigen difference, etc. Dual antibody disease occurs in about a quarter to half of the patients. Slightly older patients with more systemic features, relapses are common, but outcomes are similar or better. Drug-induced anti-GBM is also gaining prominence, especially after the COVID period, and people are comparing pre-COVID and post-COVID anti-GBM data, saying that there may be a slight increase. So, with this background in mind, we'd like to tell you about the Indian experience. The rationale this came up as we conduct weekly, meetings among many pediatric centers in the country. So, one of the cases presented was anti-GBM disease, and sir suggested to collate evidence. So, because of lack of evidence, lack of pediatric, especially Indian data, high preponderance of ESKD, and maybe possible therapeutic targets, we better be prepared and collect our data before proceeding. So it was just a simple retrospective multi-center study, and any child less than 18 years who had either serological or biopsy evidence of anti-GBM would be enrolled into the study. This is currently approved by 2 centers in the ethics committee, and other ethics committee review board are pending. So we had 7 centers participating and providing data on 18 patients, which is reasonably a big number when compared to the previous literature. However, definitely we would want to include more children if their data is available. From Delhi, 2 centers have given data. From Gujarat, 1 center. All are very good, excellent pediatric nephrology centers. We have about 6 patients, and Trivandrum has given 2 patients. So these are the clinical features of the children at onset. When compared to other glomerular diseases, this disease, unfortunately, in our cohort, it is predominantly a female predominant disease, which an adolescent or age at onset. Patients presented mostly acutely with or without getting treatment from outside with about 2 to 3 weeks of presentation, onset of symptoms. And the renal presentation as an RPGN was a predominant feature, even though 1 or 2 patients presented like an RPGN, but because of shrunken kidneys at onset itself, we presumed ESKD at onset in 1 child. 2 children presented with acute glomerulonephritis, and it is heartening to say that these children did respond very well to therapy, which I'll come to in later slides. Pulmonary hemorrhage and pulmonary edema, a stomy course was seen in about 5 patients in total, a stomy course in about 3, skin rash in 2, and joint involvement in 3 patients. We tried to look at dual antibody versus only anti-GBM disease. There was no major statistical difference between both of the groups. I know that numbers are quite small. However, we will try to add more patients and see whether this actually makes any difference. At baseline, almost all children had anemia. They had normal platelets, differentiating from multiuremic syndrome or other diseases. Many of them had hypoalbuminemia and severely reduced renal function. GFR was 8 at the onset of the illness. Almost all of them had nephrotic range proteinuria to begin with normal complements. You would definitely do an ANA in these patients to rule out, because it's a differential diagnosis. ANA was 2+ in only 1 patient. ANCAs were done in almost all patients, either by IF or by ELISA. Any ANCA positivity was found in just about half of the patient. The serology of the anti-GBM was positive in only 80% of the patient that we had. And the other patients had the biopsy positive findings. That may be the serology negative variants. The values were, the units were different at different centers, however, we can't make a comparison. Any abnormal chest X-ray or CT findings were found in 1/3 of patients. So 1 patient had actually no clinical abnormality of pulmonary hemorrhage, however, had anemia and diffuse patches in the X-ray. However, the patient did not require any respiratory support and did well. Kidney biopsy was performed in all but 1 patient with adequate number of glomeruli. Any sort of crescent was found in about 80% of all the patients. With surprisingly or not surprisingly, the IFTA, that is the interstitial fibrosis tubular atrophy, was not so severe. We would expect a severe this one, but however, as we saw in the baseline features, patients presented quite early, and also the disease looks like it was of a recent onset, and linear IgG positivity in almost all the patients. Patients were managed with standard of care. Methylprednisolone pulses were given to all the patients. Cyclophosphamide was provided in 95% of the patients, with oral cyclophosphamide being given in 4 patients. Those were the ones, I think 2 of them had only presented with acute glomerulonephritis without severe change in kidney function. Plasma exchange was performed in nearly 83% of the patients. Hemodialysis was required in 90% of the patient, and mycophenolate as a part of induction or maintenance was given in 5% of 5 patients. Methylprednisolone, 3 pulses were the standard doses given for most of the patients. Many also required IV cyclophosphamide, 4 pulses at median. And plasmapheresis, when performed, was a median time was about 10 sessions was performed in most of the patients. Many patients also required dialysis for about 2 to 3 months. However, the 5 final outcomes would be presented in the next slide. So during a follow-up median period of about 10 months, only 1 patient had relapsed in the entire cohort. 1/3 remained non-dialytic, and 20% required dialysis and continued to be on dialysis. out of the patients who required dialysis, 3 of them got transplanted, and it very gratefully they had good outcomes. And last creatinines were, GFRs were 50s, 60s, and even 70s in in the patients. Unfortunately, 3 children we know that we had definite mortality. One during the initial month, 2 during 6 to 8 months period, and 1 child after 10 years, and 2 children are and 1 child is presumed, lost to follow-up, discharged at very in a severe condition from the hospital, so presumed mortality. The anti-GBM titers after the plasma exchange, almost everyone except one patient became negative by the end of the initial therapy itself, and only one patient had a positive titer at the end of 3 months, and that patient also became negative and then continued to be negative through the rest of the follow-up. Even the ANCA titers, even positive ones, became negative after a brief, 2 weeks of plasma exchange. GFR in the patients who did well, the GFR actually became better, responded to treatment, and because of the transplant we have GFR of even up to 42 at the last follow-up. However, you can see that even a benefit from 8 to 42 is impressive, but however you should see that even in this cohort half of them don't even have a 50 a GFR of 50. Tried to do survival analysis of this patient. Overall survival in about 75% of the patients did not make a difference whether they had dual disease or only anti-GBM disease. CKD5D survival also did not make a difference. However, many patients had very early CKD, required dialysis dependent and continued dialysis dependent over 3 to 5 years. Even though it was small numbers, we tried to do risk factor analysis. However, because of the very small population, we could not get any positive risk factor for CKD free survival or death. So in conclusion, we have a predominantly female dominant disease in our cohort, which presents as RPGN in adolescents. Dual antibody disease was there about 44% of the patients. It had a reasonable response to the immunosuppressive therapy that we are given. Mortality in 28% of the patients, and transplant was done in 3 children with good outcomes. So with this, I would like to conclude my presentation. Thank you to all the faculty, all the teachers who guided, and all the faculty who provided data. Thank you.
Thank you, Dr. Georgie, for an excellent presentation. We can take 1 or 2 questions.
Georgie, we clearly require more patients to be there. So I think we need to have more numbers. So all of us who are seeing patients, I would probably request you to get in touch with Georgie and see whether we can include patients, because unless you have reasonable numbers, the data is not going to be significantly strong. Christoph, what do you feel?
I want to echo what Marina said. There is an IPNA kind of questionnaire going around, so there's another effort kind of underway. So I think to join forces would be absolutely recommended.
Yeah, there's a survey that was sent out through IRCNet, and then I think it was posted also on PedNaf. I'm not sure. Matko Marlies at Great Ormond Street Hospital
Yeah,
is.
no, I'm aware, but I think
Okay.
Georgie had begun doing this before this, so we kind
Right.
of,
And this is more
it
detailed.
was a conscious decision to stay
Okay.
out. We are aware, that, and I think there's one center who's kind of from India who's including, so I would request them also to join. But it was because Georgie had begun earlier, so we kind of discussed within our group, and yeah.
No, it's just because I know that even that is, they have like, minuscule numbers. So it's just it is so rare that it might be more precious if you can put everything together. But I understand the dilemma. I completely understand it. But on the other hand, it's a shame if then in the end you can't really get a message or understand really what's going on. I don't think they've collected more than 25 or something.
Dual ownership.
Had a recurrence of as an acute GN, and patient was from here only. Just can tell about it. Had ANCA disease. Had ANCA disease. That's more like it. Yes. Tara, Trisha. Tara.
We can close this session and go on to the next session. Thank you.
We'll break for a tea, a small 10-minute session, please. Please, everyone join by 4 p.m. I request the delegates who are presenting research presentation to please give their slides right now so that I can upload it. I'll just show you.